All right, we'll go ahead and get started. My name is Laura Rice. I am the moderator for today's session. This is IC 21, Maximizing the Impact of Rehabilitative Seating Services, the Importance of Follow-Up. So I'll be moderating today's session and we'll provide the CEU code at the end. Please make sure that you mute yourself as we get started. Questions primarily should be asked in the chat. We have a pretty big group today. However, if you have a question you think is better suited to be asked, please raise your hand and I'll call on you during the question and answer period. All right, so I will turn it over now to Dr. Masselink.
Thank you so much. So I had originally hoped for this to be a pretty discussion-based collaborative session, and I know Zoom probably isn't going to make that much very easy on us, but please, if you have any questions or anything, I'll try to keep an eye on the chat too. Please feel free to throw it out during this, because one of the issues in service implementation is that everybody has a different situation. And so if we can get a gauge on people's situations, then we can help better. And I want this to be as practical as possible. So thank you so much for attending. I've titled this Maximizing the Impact of Rehab Seating Services. I feel pretty passionate about follow-up. A little bit about me professionally, just so if you don't know, I have been an OT since 2003. I graduated from Western Michigan University, and I practiced down in Tennessee and up here in Michigan in a variety of different settings, from home health to acute care to orthopedics. I've had my ATP since 2012. So around 2009, I moved back to Michigan, and I was working at Mary Free Bed in Grand Rapids, Michigan. And there was a assistive technology department there. And I worked in that for quite a few years, ended up managing it. And then after advocating for so many years on a one-to-one basis and with insurance companies to try to get people the equipment they need, I decided to go back to school and get my PhD to try to do research and help advocate on a greater scale. And so I graduated with that in 2019, and I am currently an assistant professor at Western Michigan University in occupational therapy. And I am currently the executive director for the Clinician Task Force. And I see some members on here. So hello. If you don't know what the CTF is, we are a nonprofit organization of over 80 members across the United States who are experts in wheelchair seating and mobility services. Our website is cliniciantaskforce.us, and there's a lot of great free resources on there, and feel free to check us out. And if you're a clinician or a healthcare provider, feel free to reach out about becoming a member if you'd like. So personally, I always think it's important to get to know people personally too. So this is my family. I have 4 kids. This was us last Easter. We not homeschooled. I did not do that. I virtual schooled. We tried to virtual school our kids. And it didn't go so well, but this was one of the highlights. We built an indoor arena that we could ride our horses in. And we have a rotating number of horses, chickens, dogs, and cats, and a mini donkey. And I'm very thankful that my kids are back in school this year. So I love them, but there's a lot going on. We do a lot, and it's not easy to homeschool. So for you who do, my hands are out to you. So today, what I would like to do is relate the main results of a study I've completed examining the service delivery of wheelchairs in a dedicated seating department to best practice methods. I'd like to look at equipment categories and timelines for equipment changes. And often cited complaint of wheelchair seating services is how long it takes. So I decided to investigate that a little bit and look at the risks for wheelchair users who do not receive follow-up PT or OT services. I'd like to relate common healthcare and organizational barriers, and then also examine some strategies to overcome each barrier. And this is where the collaborative piece was really going to come in, is examining our very own clinical barriers to providing follow-up services and trying to come up with strategies to overcome them. So we'll do our best on that one. So when we get into the CRT evaluation, the CRT evaluation encompasses really 8 steps, and then we have documentation and the delivery and fitting. And when we look at this is actually, this checklist here is taken from a CTF document that we produced this year. In the CTF, our clinical coverage work group worked on this, and I just thought it fit so well here. So it goes through steps of the clinician process. So the Wheelchair Service Provision Guide by RESNA really discusses the entire process, and this hones in a little bit closer on the clinician itself. So the goal of the CRT evaluation is to look at the wheelchair user's unique needs and then determine and medically justify the appropriate wheelchair. And so I propose an equation for you. We have the CRT evaluation, we have an appropriate wheelchair, but what outcomes really make this meaningful for the person? What kind of outcomes are we looking for from this? And go ahead and think about it a minute. You can type something in if you want, you're welcome to. But I think that there's a lot of different answers to this question. So just think about it. What would a successful outcome be from the CRT evaluation when you have an appropriate wheelchair? What kinds of things do we want that person to do? Earlier in the opening message, they talked about the wheelchair maybe being something that actually limits the wheelchair user's potential, right? And I know we don't want that, hopefully. So what kind of outcomes do we want? So what is the goal of a CRT evaluation? And like I just said, those answers come from a lot of different places. So the US medical system, they're often going to say that we want that wheelchair to address current medical needs, and that's it, right? Good. So yeah, we do want somebody to actually use the device, right? And get to work. Full self-actualization and maximize function. Tabitha, I love it. A little bit different than what the US medical system is saying. The World Health Organization gets a little bit more global, right? Laura, getting into those meaningful activities, saying that it's universally recognized that an appropriate wheelchair is a precondition to enjoying equal opportunities and rights, and for securing inclusion and participation. Our professional ethics also join in on this. And so I took the one from AOTA because I feel like it really fits the best. I got to move my chat box a minute. But it says professional ethics, promoting inclusion, participation, safety, and well-being for all recipients of service in various stages of life, health, and illness. And I like that. So no, it's not pertaining specifically to adaptive equipment and assistive technology, but in my mind, for my professional ethics, I can't separate the two between my clinical services and the equipment that I provide my patient and train them in to be able to really fully maximize their function and their independence and their quality of life. And so I encourage you to look and to think about, there it is, what it means to you, okay, and what you think. And the reason is that if we are just there to do our daily work every day, and we're like, okay, we're done, we're clocking out at 4:30 and we're going home, then it might be that the goal of a CRT evaluation is to address the person's current medical needs, get them the most appropriate wheelchair, and then that's the end of your day. And there are some phases in life where really that's probably what happens, and that's okay. But at the other end, if what we're doing is really trying to promote this participation and enhance this quality of life and see the people we're working with engage in meaningful activities, then we likely have to take a little bit more of an advocacy and a more prospective focus so that we can try to overcome some of these barriers within our healthcare system. Okay, so it's complex for a reason, right? We have the complex rehab technology process, and many of you, I'm sure, are very familiar with this. But we start with the physician referral. We go into an OT and PT evaluation and equipment trials, write a letter of medical necessity, write up our documentation and submit it to the funding source. The funding source either denies all or part of it, responds with questions, and then we get an approval, hopefully. Otherwise, if it responds with questions, we need to investigate and advocate those because the person is not going to get the appropriate wheelchair without that. There's been some good sessions on that already today. And then hopefully once it's approved, the DME supplier is going to deliver that. And then we have wheelchair skills training and we customize the equipment. And I put this in a red box because this part right here is what enables the client to use their acquired equipment, right? We don't get our smartphone and know how to use it right away. It takes at least a month or two for us to get used to it if it's a new model. And we don't get a new computer without setting up the settings the way that we want them to be set. And it's got to be the same with a wheelchair. One and done it can't be that way. So we need to go a little bit deeper in order to enable the client to use their acquired equipment. So what do we think about our maximum potential and how are we going to define this? The World Health Organization says that the maximum potential to enhance quality of life needs to look at safety and durability of the equipment, the availability and sustainability of the equipment, as well as the environment that the person is using it in and meeting the person's needs. And that's going to be different for different locations. But when we look at it a little closer, we want to think about the person's ability to reach for and transport objects in their wheelchair. The ability of that wheelchair to accommodate to transportation. So can we fold and unfold it, put it in the back of a car? Can the person load or unload it? What does a person need for health and comfort in their wheelchair, right? Do they have a history of pressure injuries, or do they have a lot of chronic pain we have to accommodate for? What's going to make them comfortable? What postural needs do they have? What supports do they need for their optimal posture? When they're driving and propelling, can they do it independently all day? How often are they trying to mobilize themselves, and what's going to support them to participate? And then in the environment, we're going to look at the physical and social, turning radius, inclines, curbs, obstacles, stairs, the terrain that the people live in, right? Does somebody live rurally where they might have to go over rocks or an uneven ground often, or do they have carpet and tile in their home? Looking at their transfers, right? Can they transfer to a level surface, and then also egress? How can they manage their doors? And culturally and socially, what is the stigma surrounding the adaptive equipment or assistive technology we're trying to recommend for them? So I propose this equation for the future, that maybe we have a CRT evaluation and that leads to an appropriate wheelchair. And together that will help the person reach their maximum potential. But in order to make this happen, like I stated earlier, we have got to hone in on that participate in delivery, fitting, and training a little bit more. So we need to look at what does it really mean to follow up with wheelchair equipment and what can we do about it? And so that's what we're going to spend the rest of this session talking about. In a clinical follow-up, just briefly to introduce us to this, we really want to focus on the client's goals, their comfort, the fit in their wheelchair, the maneuverability of the wheelchair, the safety of the person. We might look at for people in manual wheelchairs, what is their propulsion method? Help them be as efficient as possible with propelling their wheelchair. For people in power wheelchairs with different power options, we might need to look at the power options they're using. When do they need to use it for pressure relief, or when do they need to use it to reach for an object, and how are they going to do that? What setting really works for that person? Are they able to recall the directions of doing an optimal pressure relief with tilt and recline, or do we need some smart system that might help program it for that person? Additionally, when we look at maneuverability and fit, we want to look at the angles of the wheelchair for manual wheelchairs for sure. And we want to look at the electronic aspects of the power wheelchairs and see if anything needs to be customized or tailored for that person. So those are some things in a follow-up session, even if there's only one follow-up session that we really want to be sure to address. And then maybe we need to refer that person on, but that's the basis of a wheelchair follow-up. So you might be thinking, I'm an excellent therapist, I already do this stuff. Like, I already got it, Cara, you're preaching to the choir. And I'm sure that that's true for, I would hope, if I'm preaching to the choir, that's awesome. I will preach for this whole hour then. So But what we see in evidence is that DiCiano et al. In 2018, they documented that long insurance approval processes may impact equipment delivery. That Greer in 2012, with their literature review, said that it isn't clear if many follow-up visits actually occur, even though they proposed that in their framework. Suzuki et al. In 2000 said that their specialty wheelchair clinic clients reported a decrease in satisfaction after the evaluation. So suggesting that something is happening between the evaluation and the clients getting their wheelchair, and maybe even beyond, where satisfaction has gone down. Zhang et al. Examined emergency room visits related to wheelchairs and tallied that many wheelchair-related accidents do occur during use. Hogaboom et al. And Werwerby, over probably a period of the last 10 to 15 years, have documented about wheelchair breakdowns and researched them. I think there's probably 5 or 6 studies in this study where they talk about wheelchair breakdowns, how they can result in pain, missed medical appointments, work, school, result in pressure injuries, and more. And then finally, this last year, I had a research study published discussing recommended equipment versus delivered equipment. So is what therapists recommend the same as what is delivered by insurance or by the DME supplier? And what I found was that no, it's not. So we're going to go into that a little bit more. In 2017, I examined wheelchair recommendations from 2017. And the recommendations made in 2017 following up with what was actually delivered. And what I found was that significant differences were found in all categories between what was recommended and what was delivered. So categories assessed were wheelchair bases. We have manual wheelchairs and power mobility devices. I encourage anybody who's doing research in wheelchairs to please categorize their wheelchair by quality, or not quality, complexity, sorry, wrong word. So that we can at least start to make some relationships between equipment complexity and results. But manual wheelchairs, we looked at 6 categories. In power mobility devices, we looked at 5 categories. Looked at cushions, divided largely by HCPCS coding, all wheelchair bases. And then for backs, for all wheelchair bases, so standard, general use, posterior positioning, and planar. And then power options are not really categorized. But we categorize them into these categories, okay? So we looked at power mobility devices with no power options, elevating legs or seat elevation, tilt or recline with elevating legs or seat elevator all the way on up. So looking more at the differently delivered equipment in these studies, we find that the most recommended equipment we're in the complex adult manual wheelchairs, and I need to move the chat, but I'm pretty sure it's group 3. Yes, power wheelchairs. Just didn't want to say that wrong. So out of all of the, and this was a cohort. Could you try again? Oh, thanks, Siri. I appreciate that. Sorry. This was a dedicated seating department that saw people of all ages. So from 0, not 0, but probably like 1 or 2 all the way up through 99. So whoever needed a wheelchair and was going to get a therapist recommendation for it, this was an outpatient department that would see them, including some inpatients. So the most not delivered wheelchair bases were adult tilt-in space at a 9.7%. Of what was recommended, complex adult manual wheelchairs at 11.2%, group 3 power wheelchairs at 17.5%, and then group 2 power wheelchairs at 24%. Most not delivered cushions were the general use at 19%, skin protection and positioning adjustable at 23%. And then the most not delivered backs were the positioning posterior and the standard. So you kind of see there's this range between what is standard and what is more complex, commonly a more complex patient, as to where the things that were not delivered the most often. So when I say not delivered, I am not saying that something else was delivered in its place. I'm saying it wasn't delivered at all. So in the study, I did have counts of what was recommended and what was delivered. I didn't go into that for this presentation, but when I'm saying not delivered, then I'm saying not delivered. No, Teresa, I did not look at FMA data. This was a single organization study, one dedicated CD department. Yeah. Yep. Megan, we'll get into the reasons in a little bit. Okay. So yeah, we'll get there. Yes, let me address that in a little bit. So the most not delivered power options were tilt or recline with elevating legs or seat elevator at 30%, and then tilt and recline with elevating legs or a seat elevator at 33%. So you can see that as we went from not delivered wheelchair bases, it was more common that a power option was not going to be delivered than a cushion or even a back or a wheelchair base. So we tried to predict differences through a logistic regression. We looked at sex, age, insurance type, and equipment type, and we could not predict differences for power mobility devices. And the manual wheelchair bases were 7% more likely to be different for each year decrease in age. Jillian, so I looked at the letter of medical necessity and coded what was recommended for the therapist. And then I looked at the DME supplier, worked with the most common DME suppliers in the area that service this clinic, and looked at the claims for the DME supplier. So no, it was not reported by the patient. It was through DME supplier claims. So I followed the process through. Let me know if you have more questions on that, though. That's a good question. So then I also looked at the timeline for equipment recommendations. Overall, the equipment that was delivered took about 6 months to be delivered. And then in relationship to timeline, standard and complex power mobility devices were associated with longer timelines. The manual wheelchairs were not, and only the timeline for complex power wheelchairs were significantly associated with public funding sources. So when we look at it, what we really find is that the complex power wheelchairs, so like group 3 power wheelchairs that are going to public funding sources of Medicare or Medicaid, are the ones with the longer timelines, significantly longer timelines. So on to the reasons, Megan. I did not, as I went through coding, the reasons was not a part of the study. So I don't have results as far as frequency on these answers, but I do have some of the reasons definitely came through. So the documentation and insurance process was about 6 months. And what I found is that there really were reasons that attributed to the person, and then to the funding source, and then to the DME supplier. So during the 6-month timeline, sometimes people moved, and so they just weren't going to receive their equipment. On the same, even sometimes they transferred into long-term care, and some of them passed away. Some of them had another medical incident where they weren't able to fit in the wheelchair anymore, or they needed a different one. Some of them gained or lost weight, and so they needed different accessories, or they gained or lost function. The funding source sometimes denied all or part of the base or accessories and would not provide it. Sometimes they had requested additional information on why specific parts or pieces are needed. We know that this happens, but sometimes they just suggested alternatives and said, we think that you should supply this one instead. So I didn't get into that a whole lot, but I know that that happened. And so some of the stuff that wasn't, some of the equipment that was delivered differently than what was recommended. And then finally, the paperwork sometimes got lost or it wasn't signed in time, right? Megan, I only followed appeals if they had eventually delivered the equipment. Okay, so if they didn't eventually deliver the equipment, then I did not. If they did eventually deliver the equipment, then that was coded, but I didn't specifically separate out appeals and look at that because there really wasn't a good system to do that, unfortunately. So, yeah, does anybody else have any questions about that? I'm happy to answer them before I go into the next part. Julie, did I track what the length of time was for each part of the process? I only tracked the timeline between the equipment evaluation through the date of delivery. So now we know, right, that things happen there. Like sometimes it takes a week or two for the equipment, the documentation to happen, and then it goes to the supplier, and then it takes a couple of weeks for processing, and then it goes to the funding source, and it takes time for processing. But what I really honed in on in this study was the time between equipment evaluation and recommendation. I do have another study I'm hoping to do in the future. Actually, I've done it. I just need to write it up. But on recurring wheelchair, who was like recurring visits, not necessarily if they had equipment recommended or not, but who needed frequent seating services. So hopefully I'll get that written up soon. But thanks, Teresa. All right, if more questions come, feel free to throw them out there. So there is more evidence, and it's positive this time, because what we've been talking about, I don't think is very positive. But Hansen et al. In 2004 produced a study, and they discussed an active follow-up. So they assessed the wheelchair user seating comfort, maneuverability, transportation, and safety, and found that 99% of the wheelchairs who received an active follow-up, and there was a control group to this study, but they needed maintenance. And then they also found, yay, that intervention reduced accidents. So that's really exciting to me, because it shows that we can change things, okay? Additionally, Kirby et al. In the wheelchair maintenance training program discussed follow-up and skills, and they say that training of specific skills the wheelchair user may need or advising on maintenance programs should be an important part of follow-up visits, with referral for further clinical or supplier support as needed. So we can make this better, right? We can, through communication, follow-up training, education, hopefully we can make this better. So the complex rehabilitation technology process is really in-depth and kind of intense to go through. But one of the things I want to encourage as well is, if you're not in touch with your CRT suppliers, sorry, be in touch with your CRT suppliers. So you share documents or consistently schedule meetings where you review the status of shared clients, so that you can know when their equipment is being delivered. See if you can have it delivered at your clinic. That might work, so that then you can be involved in the fit process. There also is some supplier specific software that's starting to be used. I'm really excited about this. NewMotion has the NewMotion app. I'm really hoping that a lot of the suppliers will include in the clinician perspective in these apps or software as they're creating them, allowing a patient to elect that a clinician can see the status of their equipment as well, so that then we all can have that team approach. The team approach is so very important. So I think there's some things during the process that we can do, hopefully, to make things a little bit better, and then recognize that when we can get re-involved. Okay, so what the evidence says about follow-up at or within 1 month of delivery, that it's a good idea for clinicians to assess equipment fit and function. Okay, so the one of the things they ask is the wheelchair set up to maximize the client health and function in their various environments? Is the client positioned well? And Michelle Lang has some really great resources for that. And then, are the propelling or drive methods accessible and programmed or appropriately customized? So I'm sure, as with all of you, but I've had patients come back in a month or two after. I have one really sad. It was really sad to me. She came back in, and it was for a different reason, but we were talking. I was like, how is your wheelchair going? And she goes, I'm just such a terrible driver. I just keep running into things. And I'm like, that's not your fault. Like, that's not your fault at all. Like, you're not a terrible driver. The wheelchair isn't working well for you right now. Let's get that fixed. And there's no reason why somebody should feel bad about their drive. Certainly, we have people who are poor drivers of cars, but there are enough electronics on these wheelchairs that hopefully a reprogramming made her feel a whole lot better about her wheelchair use. So looking at the propelling, looking at the drive methods and saying, how is this working for you? Secondly, use an outcome measure. So in the clinician checklist, there's some outcome measures that are recommended. But I definitely highly recommend that if you use one of them at evaluation, use it at follow-up to get more information. The life space assessment, the wheelchair user confidence scale, the wheelchair skills test questionnaire, and the FMA are a couple of examples that are really good to help capture some objective outcomes. And I am a true believer that if we want to make change in this area and help make change, we have got to start doing some outcome measures to help show what an impact our services make. For training and education, for wheelchair skills, we want to look at the handling of the wheelchair, right? How is the person doing on transfers, their indoor-outdoor usage, their caregiver training? The wheelchair skills training program that's one that a lot of people know, but they have some really great information online and it's readily accessible. And so using that program to examine what needs the clients have in their wheelchair skills and assess them is a really great idea. And then the wheelchair maintenance training program, maintenance isn't something that we as therapists typically, I don't think, cover. A lot of times we leave that to the DME suppliers. But the wheelchair maintenance training program, if you go to this UPIT website, you log in or you give them your information, and there's two 5 or 10 minute videos, one on manual wheelchairs and one on power wheelchairs. And it just goes through a basic, here's what you should be checking on your power wheelchair, here's what you should be seeing why, and then you can go through. So training your client in that, showing them where that is going to help hopefully to prevent some of those injuries and accidents that we talked about earlier. Yes, Trish, I would love to insist that the wheelchair is delivered with the therapist there. This right here, this appendix was the checklist that the Hansen article or study used for their active wheelchair follow-ups. And they did this at 1 year post-delivery. You'll see here that they looked at seating comfort. So they reassessed the person's seat width, seat depth, backrest height, seating angle, upholstery, foot plates, leg rest, arm rest, trunk supports. What they found too is going through this with the patient, educated the patient, and the patient then knew what to look for, which is awesome. I mean, if I can show somebody what to do, that's great. For maneuverability, they looked at the axle position, hand rims, driving belts, casters and caster fork housing, tipping lever, push handles, brakes, seat elevation, the user's opinion. So getting some subjective and a little bit more objective in there. Transportation, which we know is very important. And then safety with use and some of the safety features for wheelchairs. And then general. So the user's opinion of the wheelchair is a test driven by the OT, and the user has a user's manual. Bailey et al., they used the life space assessment and wheelchair users confidence scale at 18 months to follow up. And then, another option is client initiated. But for a new wheelchair user, I really feel like really encouraging them to set something up at least 1 month post and then 6 months to a year out is really going to be helpful. Allison, I'm going to take just a minute and read this. Working in outpatient, I also struggle to sometimes recommend clinic delivery for wheelchairs specified with. Yeah. Do you struggle to recommend wheelchair or clinic delivery for wheelchairs, or do you struggle with that not being recommended?
I should say it that way. It's oh, I wasn't sure if I was unmuted or not.
You are unmuted, yeah.
Well, thank you. More often it's getting buy-in. I should rephrase that from the inpatient therapists on the value of what it sees, what happens after they leave, and yeah, so it's more often the inpatient therapist, I think, needing some reminders that would be of great benefit.
Yes. No, I can see that for sure. And if anybody has any suggestions for Allison, put them in there. Allison, I'll come up. I have a couple of resources that might be helpful for you as we go through these further recommendations. Even my friend Nicola Burge, Nicola, I don't know if you're here. I think she might be in another talk, but she created, and I think a lot of places have this, but like a postcard for the equipment process. And if something like that could be given out to the inpatient at discharge, that has information for their wheelchair and maybe for the seating clinic, that would be really helpful. It's hard because you get so much stuff at inpatient discharge and so much information, but at the same time, there's some stuff that's really important like this. It all seems really important at that point in time,
That's a very good point, and that's a good suggestion. I'll keep that in mind, but you're right. I think they get so many things when they leave the hospital, plus they're just plain overwhelmed to begin with.
Yeah.
That I think, because a lot of times I think there is information, but it's embedded within their discharge paperwork, of several pages of many things that are of equal or greater importance. And that's a good point though, but maybe something separate and distinct would be helpful.
Yeah. Oh, hey, Nicole. Yeah. So there's Nicole. If you want to reach out to her, she's happy to share the document. So you're welcome to. And thanks, Katie. So you've been working on that process too. You found that it's really been helpful to talk about the negative outcomes that are seen later in outpatient that we have no way to know about in the inpatient side since we never see that patient again. And that's true. I used to do quite a few in services for inpatient therapists if I could, and be there too on the unit every once in a while if I could be, and be available for questions. And yeah, Megan, I agree that the vendor ATP should hopefully, be able to carry on that expectation too. And maybe that too, if the vendor ATP can, even if they follow up with a client, but it's hard to know if they are going to follow up with the client at home health and if it will be the same vendor or not. But oh, good, Marlene, thank you. So another session running right now that discusses is closing the gap for people needing CRT through inpatient rehab and outpatient collaboration. Yep. And I think Kathy Carver has been looking at this too. So I'm hopeful that there's a few more resources that are coming. Ooh, Andrea, I like that. Your seating clinic would be pulled in to consult with the inpatients who are more complex, and then you would follow up after discharge. And that might be too, if you have the resources, which is always a hard word, if you have the resources to be able to follow up after discharge, that would be awesome. Cool. Thanks, Tori. Okay, I'm going to move on just a little bit, but you all continue throwing stuff out in there in the chat. I love it. So the feasibility of follow-up appointments, we're going to talk just briefly, and this is where, I hope to have more discussion too. So relating some of those common healthcare and organizational barriers to providing follow-up services. So I find that providing follow-up services really depends on, I'm going to put them into 3 factors, okay? So the person factors, organization factors, and then the greater healthcare system factors. In the person factors, often we can be discouraged to follow up by transportation, the person's health status, they're just overwhelmed with getting home from inpatient rehab, the caregiver support and what the caregivers have going on. Often, that burden of having to come in for another visit can be difficult. And so billing is definitely an issue, Barbara. So factors of organization, I think, are also, I'm going to put clinician knowledge under these factors, and I'll explain why in a minute, and productivity requirements, and then also scheduling and department setup. Depending on the way that your department is set up and scheduling happens, I have come into a ton of barriers with follow-up visits because of these factors. And then also for coverage, in order to get these visits covered under healthcare guidelines, sometimes we have encounter links, or sometimes we have documentation requirements in clinical sessions. And Trish, I will tell you that we had a lot of issues with, I think this relates to what you're saying in that. So you're talking about deadlines for delivering ASAP. When we tried to implement follow-up visits, we had scheduling requirements, and often because our evaluations and how they were scheduled, the delivery had to be scheduled out. And that was not like, we couldn't do that either, right, for the DME suppliers and for the patient who needed their wheelchair. So there can be a whole lot of barriers when we're coming into this, but trying to identify where the true barriers lie for your organization is really important for you before we move forward. Yeah, Julie. So for person barriers and for those therapists, when it's not efficient and they're delivering the equipment at home and you can't drive there, telehealth may be a really good option. I agree, Barbara, that if possible, even having the client come in a month later, if it's not an in-depth complex patient who needs our eyes on them right now, having the client come in a month later and doing an active follow-up like that might be a really good option for the client, so that they can have their experience with a wheelchair and then ask questions and really know how it works for them. The CTF created this document with the telehealth flow chart this last year with COVID, but hoping that telehealth goes on into the next year. The CTF has been doing quite a bit of advocacy to ensure that PTs and OTs are included on legislation for telehealth. And so this document, this flow chart, just gives some criteria for people to think about, for clinicians to think about when scheduling telehealth options. Another option has for wheelchair skills training too, is that there are some virtual monitor programs. One that I came across that I don't have a whole lot of experience with is this training to enhance adaptation and management for wheelchair users. Of course, the wheelchair skills program also has quite a few resources online, but meeting the person online in telehealth so that we can see some of what's happening might be a really good choice. This relates also to some of those organization barriers. So I put this out here. I feel like this is a little bit more of a clinician knowledge thing. We've come into it quite a bit recently where people can't conceptualize how telehealth might work for CRT products. And that's fair, right? Like it can be fair, but what we did was queried some of the therapists in the CTF and gathered examples of PTs and OTs using telehealth for CRT. This is available on our website, which is listed right there. And if you or other people, we've used this for legislation as well, and for advocating for legislation. We're about ready to use it for MIOTA for our lobby days, where we can pass on these 12 examples of PTs and OTs using telehealth. They're easy to read, that demonstrate why telehealth was a really important part of the service delivery process. And like some of the comments have said, it's not that we're doing the whole thing by telehealth, but for the delivery process, or doing one visit when we really can't figure out why this person's pressure injury isn't healing, or doing it because a person doesn't have transportation to get to the appointment initially because they don't have a seating and mobility equipment, can be something that we might want to do. So feel free. So please educate yourself and others on examples for using the telehealth with the CRT. And then also the clinician checklist is available, and the wheelchair service provision guide. If productivity is an issue where you're like, I have 90% productivity requirements and this is just a huge drain, I always told my clinicians that follow-up visits, I feel like, are actually something that are good for their scheduling because they're re-seeing a client. And so hopefully it should be good for your productivity because you don't have the demands of the evaluation and writing up the letter of medical necessity the whole time. So if your place does have some productivity requirements that are not in line with what seating and mobility needs, We had an outpatient PT. He was an ortho PT, and you know those guys can like crank out those treatments, and they can see 2 people, 3 people at a time that we're never going to do. But using something like the clinician checklist and the wheelchair service provision guide might help to show the real need for altered productivity requirements for seating and mobility. Great, Tamara. I'm glad that you found that. Organization, scheduling, department, and healthcare needs. So inpatient to outpatient, when you're an inpatient or an outpatient therapist seeing patients for their wheelchair needs, but also seeing other needs, it's often, I think maybe a little bit easier because you're going to often continue treatment while you're waiting for the wheelchair delivery. But for seating and mobility departments, we're often concurrent to traditional therapy services. And so there's going to be a hold, right? Often the patients cannot continue seating and mobility services while waiting for the equipment because there's nothing to work on. And so I think taking these 2 beasts just a little bit differently is important. Looking at follow-up sessions and scheduling overall of the services, it depends on how your scheduling works, of course, but if you're seeing a patient for different evaluation lengths, like maybe your evaluations are 2 hours long for one session, trying to make your evaluations, I'm sorry, I'm getting into the next slide already. On this slide, some of the obstacles might be that your session times are at a different length, but also that your traditional evaluation documentation may not be completed, because sometimes I've seen it used where the letter of medical necessity is used to describe the billable clinical services, which in an in-depth letter of medical necessity, I think is fine, but then treatment plans and goals may not be defined. Erin, always pros and cons, right? So the length of time between the evaluation and intervention also, if it's around approximately 6 months, then you need to often have some periodic documentation or physician orders to maintain the encounter open. And that can be difficult too. It's additional administrative support that's needed that's not getting covered. Okay, so here's a few potential services. Karen, the 97755 code, you can, are you talking about for follow-up? Are you following the chat, or is that something for this? I just want to make sure I'm understanding your question. Okay. Then I'm going to get back to that in just a minute. Or somebody else. That sounds good. So for potential solutions for seating and mobility services, one of the things that we trialed that worked pretty good was a 1-hour PT or OT evaluation, and then doing a 1-hour follow-up with the CRT supplier that we could bill for treatment. And I'll say that for these 2, you know, there were times it wasn't something that the therapists I worked with were very important, but yes, being able to tell the person up front the time commitment was key, right? So we had to be sure that the patient understood that this was the way it was going. This makes 1-hour follow-up sessions easier to schedule. So if you can get everything kind of on the same time schedule, and honestly, like we are doing a PT and OT evaluation, and then we could tailor our equipment and have everything in line. I felt like it was better for the client because then that other hour could be dedicated to device trials rather than it was just I guess I'm a little bit more in a black and white and precise person maybe, so maybe that's why, but it made sense to me. The other thing is that when you're doing something like that, trying to make the LAMEN so that it meets the requirements of the OT evaluation, but also can be used to document clinical services so that we're not having to do extra work, right? It's not that we want to do extra work. We want the client to get what they need, but we also need it to be efficient. So in the world of EMR, and honestly, where I worked, we still used Word documents except for the MS 1656 that is required in our state. So this one really depends on the facility that you're working in. On the healthcare barrier side, I have this future vision, okay? And I don't know if it's probably a pipe dream, but I think there's a lot of need for traditional clinical services where we evaluate a client, we do intervention times a number of weeks, and then we discharge them, right? They set goals, etc. But I also think that there's a very economic clinical model that we're not tapping into and that healthcare doesn't cover very well. And that is the one where we go in and we evaluate, we do equipment recommendations of 1 to 2 sessions. And then there's like a hold that we can put on the patient until equipment is done or environmental alterations are done. And then we can follow up with that person and do 1 to 2 sessions in a much more feasible, administrative, less administrative burden type of way. And so I don't know. In the future, I would love to advocate for this different model of clinical services. It's not significantly different, but there's a few areas such as like disability advocates around our area does home evaluations, and then they recommend equipment or environmental modifications, and then they go in and train the person in 1 to 2 sessions. And I think that trying to advocate for some of these clinical consultative services and making them a little bit less burdensome might be something that might work for some seating departments. All right, and that's what I have. Here are my references, but I would love to hear from some people, especially people who are following the chat or who have questions and would like to speak up or give your 2 cents or what you've done. I would love that if anybody is willing.
So I think most of the questions in the chat have been addressed, but if we haven't addressed those, please speak up. There's so much good conversation. I can't keep track of what hasn't been answered, but I think most of it has been.
Barbara and Aaron, I see some things from you all, or Trish, do you want to give some insight on what you were doing or what you've done?
Sure. Cara, I just want to say I really agree with you about the follow-up. So when I was at Provale in the assistive technology clinic, it was kind of a unique situation because we were doing seating, but we were also doing ongoing sessions with people. So when somebody came in for an OT evaluation and their major presenting issue was that they want a new chair, we would also see if there were other goals that the person had. And so if they had some other goals for maybe accessing their technology better, or they needed to get some things in place to manage their health better or their exercise routine better, we would include those goals in the plan of care, so that one of the goals was the new chair, but there might also be some learning goals about accessing their assistive technology or putting a exercise plan in place. And so then we would have some goals that we could work on while we were waiting for the equipment to come in. And we would have a goal about self-advocacy so that we could work on some of those things in session in terms of follow-up that doesn't have me doing everything for patients, when some of those things are really more appropriately things for them to learn how to do and make those phone calls and follow up with that supplier and follow up with their doctor, so that they can take on a little bit more active role. And that was useful.
Mm-hmm. I love that thought of having a goal for self-advocacy, because then you're there going alongside the client to help them learn how to do some of that themselves. And when they have issues, then you can problem solve it. But, and the goal for them to be able to do it themselves. I don't often learn unless I'm doing. So I think that makes a whole lot of sense.
Yeah. And we found too that it was much more powerful for a client, especially a communication device user, to be calling their doctor's office and trying to find out why something hadn't been signed, than for me to call and try and like chase down where this paperwork is and does it need to be sent again, and so
Yes.
the offices would be more responsive to the person advocating for themselves.
For sure. As they should be, except that they also have so much going on, right? So
Yeah, they do. Yeah.
good point. Becky, I saw your point up here a minute ago about doing a follow-up to learn what you did wrong. And I 100% resonate with that. Like being able to follow up and see where you made your errors and reflect on your processes is definitely going to make you a better clinician.
So if I can speak, this is
Yeah.
Barbara. When I was working at Care Partners, it was much easier because the inpatient therapist would refer to the outpatient seating clinic for people who were being discharged and chairs were recommended. I often would go over there and assist. I still get called up to inpatient even though I don't work there anymore. I work on their campus in a rental space, and we're not connected. We're under different entities. But I still got called up there. So when I realized what's missing, and this, I'm so glad I attended this because it reminded me, I'm missing that piece of that referral getting to me to do the fitting. If they send it at the time of the recommendations, I can put it in my list of clients I need to see for fitting. And I know which supplier it is, and I'm in touch with them regularly, and we go over our list of things that are waiting to be delivered. And that has helped us a lot, just that one-on-one contact with the supplier to go over, okay, who are we waiting on? Where are they in the process? Let's look ahead. If you know it's coming in that week, let's see when can we get them scheduled so that it doesn't get so delayed that they don't meet their goals at the supplier place either. We try to work together. The telehealth has definitely been a big help of doing fittings when the supplier can drive the 2 hours to the client's home and the client we know doesn't have a way to transport the chair home. It makes the most sense for the supplier to take it out there if it's too difficult for the client to get into clinic and the supplier then drive it there later. We do it that way also, where they come in, we fit it, and the supplier then has to take it out the next day. There's so many ways of doing this. It all boils down to communication and staying on top of who needs to be seen and at what place they are in the process. It's a really hard thing to track.
It is so hard to track. I'm getting a notification that we have got to wrap it up, but thank you, Barbara. I really appreciate that. I 100% agree. There's so many good comments. Thank you. I'll turn it over to, yes, thank you.
Yep, so I just want to give out the code. Sorry to stop the good discussion. The code, I put it in the chat. It is 8SDLUD. And I think it got lost in some of this good conversation, so I'll put it in again so everyone can see it. So I want to thank everybody for your great conversation. It is hard to have an interactive session on Zoom, but this was really nice. So I appreciate everybody's input. Really great talk. I learned a lot. And gave me lots of good ideas for my clinic as well. So thank you so much. And I hope everybody has a great rest of their day.
Thank you.